Alright, the second chapter we're going to talk about this week is chapter 5, the abdomen and gastrointestinal system, or the GI system. Alright, so this should be review for you. There are 9 regions in the abdomen, and the abdomen has 4 quadrants, which are right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. The abdominal cavity contains the stomach, intestines, liver, gallbladder, pancreas, kidneys, ureters, and spleen. The pelvic cavity contains the distal ureter, bladder, portions of intestines, and reproductive organs. The abdominal cavity is lined with a serous membrane called the peritoneum. The serous lining covering the organs is called the visceral peritoneum. The parietal peritoneum is a serous lining that covers the abdominal and pelvic walls and extends to the abdominal organs. The mesentery is a double fold of parietal peritoneum extending from the posterior abdominal wall and attaching to the intestines. The mesentery also supports and allows for nerves, blood vessels, and lymph vessels to travel to the abdominal organs. The greater omentum is another double fold of peritoneum that attaches from the greater curvature of the stomach to the proximal duodenum and the transverse colon. It then drapes loosely over the intestines. The lesser omentum is a fold of peritoneum that attaches to the lesser curvature of the stomach and attaches to the proximal duodenum to the liver. This is another review. The alimentary tract makes up a big part of the GI tract. The alimentary tract serves to digest food and absorb food. The tract extends from the mouth all the way to the anus and includes the mouth, pharynx, esophagus, stomach, small bowel, and large bowel. Alright, on this slide it is review again. I'm also going to apologize because my husband is doing work outside, so if you hear that in this PowerPoint, I am sorry. I'm going to try to get through it though. So the small bowel is divided into 3 parts. I'm not going to go into depth in this because you should already know this. So the 3 parts are the duodenum, jejunum, and ileum. This is more anatomy that you should already know. The large intestine starts at the cecum, ends at the anus. Alright, now we jump into imaging considerations. So radiographs of the abdomen are often used as a starting point for the patients with abdominal pain or suspected abdominal pathology. Based off of what is seen in or not seen in a routine KUB, providers can plan for how to care for the patient. Abdomen x-rays are often used to observe gas and fecal patterns, placements of tubes or catheters, and checking for any bowel obstructions or perforations. As a tech, we should be able to identify the liver, kidney, spleen, and psoas muscles based on a lucent layer of fat surrounding them. Erect or left lateral decubitus are performed to see if there are few, if any, air fluid levels present. If a patient is unable to stand, a left lateral decubitus will be performed. Do you recall why a left lateral decubitus is performed instead of a right lateral decubitus? Hint, what side of the abdominal cavity does the stomach reside on? So nice little review for you. Soft tissue radiographs of the neck may be requested to get a baseline view of the neck, focusing on the larynx, upper trachea, epiglottis, and areas around the thyroid and thymus. These radiographs can show soft tissue pathologies like epiglottitis, a neck mass, or structural abnormalities of the upper airway. This image here is a lateral spot image of the oropharynx and neck captured during a modified barium swallow examination. The black arrow is showing a laryngeal penetration and the white arrow is showing aspiration of liquid barium during the examination. Penetration is the term used for material entering the laryngeal vestibule. Aspiration is the term used for material that migrates below the level of the vocal cords, which is the black circle, and into the trachea. So if you are in fluoro, you would see that we do like a lot of VFSSs with a speech pathologist, and that's typically what we are examining. Alright, so this is also something that you should probably know because you learned fluoroscopy. So a non-contrast exam will show the air within the stomach but by adding contrast agent to the study, the stomach becomes more distinct and more information can be gleaned. When contrast is added to evaluate the contour, position, or the stomach in peristaltic changes, it is called an upper GI. Upper GI include examining the esophagus, stomach, and duodenum. A few reasons why an upper GI may be performed are to examine a hiatal hernia, abdominal pain, abdominal discomfort, nausea, vomiting, anemia, GI tract bleeding, and post-op evaluation. A clinician may want to administer glucagon to relax the stomach muscles and diminish peristalsis. Crystals may be added to not only add negative contrast to the study, but it also expands the stomach and promotes coating of the mucosa in the stomach. The provider may also put pressure on the stomach to better visualize specific areas in the stomach and duodenum. Alright, so a small bowel series is done to evaluate the small intestine. Typically, the thin, low-density contrast is used because it provides the best radiographic contrast and luminal detail, so we would be using barium. This exam can take up to 2 to 3 hours to complete because the exam is not considered done until the contrast has reached the ileocecal valve. During the exam, images are taken at set intervals to monitor the motility of the GI tract and to identify any abnormalities as the contrast makes its way through the small intestine. Indications for this exam include abdominal pain, nausea, vomiting, diarrhea, anemia, GI tract bleeding, staging of inflammatory bowel disease, malabsorption, unexplained weight loss, and post-op evaluation. Again, if there's concern for a perforation, barium is not used, a water-soluble contrast agent will be utilized. Enteroclysis is a small bowel enema that can be performed to study the small intestine. This exam is done by inserting a tube through the mouth or nose and all the way down to the end of the duodenum at the ligament of Treitz. The tube may be extended into the jejunum as necessary. This exam will most often use a double contrast agent, but they can use only a single contrast agent for the study. The purpose of this exam is to gather more enhanced mucosal detail than a small bowel series can offer. The modality for this exam can be fluoro and radiography, but CT and MRI also have some versions of the exam that can be performed. To examine the large intestine more thoroughly than a conventional radiograph, contrast is introduced to the large intestine through a barium or water-soluble contrast enema. As we have discussed in previous classes, barium enemas can be performed using single contrast, but they are more routinely performed using double contrast. The negative contrast agent distends the barium-coated lumen along for improved visualization of the mucosal lining. The exam is done to demonstrate abnormalities of the large bowel. Indication for this study are incomplete or poorly prepped colonoscopies, anemia, GI tract bleeding, abdominal pain, diarrhea, constipation, fistula, IBD, and pre- and post-op changes. Just like the upper GI, when imaging the colon or large intestine, radiographs may be warranted following the study. Oblique projections profile flexures and view areas that are normally overlapped by the bowel. The AP or LPO projections utilize a cephalic angle, whereas the PA utilizes a caudal angle to view areas of overlap, most commonly for the sigmoid colon. Decubitus and ventral decubitus images demonstrate air fluid levels to examine the mucosa of the air-filled colon and rectum. After evacuating the barium sulfate mixture, post-evacuation radiographs may be performed to evaluate the contracted barium-coated lumen to check for filling defects. A surgical enterostomy is performed to create an opening between the skin and bowel to insert a tube for feeding or to create a stoma for drainage of intestinal contents. A colostomy is when a stoma is surgically created on the abdominal wall to allow drainage of the large bowel into a closed pouch hanging outside the body. An ileostomy is an opening between the ileum and the skin to divert bowel contents before they enter the colon. If a person has had a surgical enterostomy, a contrast agent may be administered through the opening that was created. Special enema tips are manufactured to administer contrast agents directly into the ostomy opening. However, a standard enema tip can also be used. Fluoroscopic contrast studies using ostomies are generally performed using a single contrast agent, and the tech should take extra care as these sites can be particularly sensitive for patients. Technologists must be familiar with each type of tube and exercise great caution when positioning individuals with abdominal tubes in place. Gastric tube can be placed due to aspiration of gastric contents to help control nausea and vomiting, decompression and removal of gastric contents because of bowel dysfunction or surgery, nutritional support, or medication administration. Gastric tubes placed through the mouth are called OG tubes or orogastric tubes, and gastric tubes placed through the nose are called NG tubes or nasogastric tubes. So we are moving on to congenital and hereditary anomalies. This is a highlight star slide. Hypertrophic pyloric stenosis, or HPS, is a congenital anomaly of the stomach in which the pyloric canal leading out of the stomach is greatly narrowed because of the hypertrophy and hyperplasia of the pyloric sphincter. To review, hyperplasia is the increase in the number of cells and hypertrophy is an increase in cell size. HPS is the most common indication for surgery in infants. The exact cause is unknown, but it seems to be genetically related. HPS occurs more frequently in Caucasians and African Americans or Asians, and 4 times more often in male children, most often in firstborn male children. A sign of HPS can occur when a previously healthy infant around 2 to 6 weeks of age starts to projectile bile-free vomit and have a persistent emesis. Infants can become dehydrated and fail to gain weight. The olive sign is an olive-shaped mass of the hypertrophied pyloric muscle that can be palpated. HPS can be diagnosed clinically without imaging, and the infant can go to surgery from there. If no olive is palpated, imaging will be done by radiography to evaluate the patient. Modalities that can be used are radiography, sonography, fluoroscopy, upper GI series, or a combination of these. Radiographs will show gastric distension, and it may also show a soft tissue mass impression of the thickened pyloric muscle. Sonography of the abdomen is the standard and highly accurate method to diagnose HPS. Sonography images of the pyloric muscle and channel and can show an elongated, thick-walled pylorus that would indicate HPS. An upper GI study would demonstrate delayed gastric emptying, accompanied by the mass impression of the hypertrophied pyloric muscle. On the barium-filled antrum, that would be a shoulder sign, the filling of the proximal pylorus, beak sign, or the entire elongated pylorus, string sign. However, these signs from an upper GI could take a while to show due to delayed gastric emptying, which would mean more fluoro time and increased radiation for the patient. So not very ideal. Treatment is to perform a surgical pyloromyotomy. Wow. That will increase the opening of the pyloric channel. Infants can generally begin normal feedings a few days after the procedure. Alright, the next thing we're going to talk about is malrotation. This is a highlight star, just so you know. Malrotations occur in utero when normal process for developing intestinal rotation is disturbed and the intestines are not in their normal positions. This can lead to the small and large bowels having abnormal fixations that predispose individuals to internal herniation and volvulus. This disease affects male and females equally and can have varying degrees of malrotation. Although rare, malrotation can possibly lead to situs inversus, which is the complete reversal of all abdominal organs. When malrotation is suspected in an infant with bilious vomiting, an upper GI series should be the examination of choice and is considered the gold standard. The exam searches for any deviation in the normal route of the duodenum from right to left of midline, as well as its turn upward to the duodenojejunal flexure, that the ligament of Treitz. An upper GI may demo a greater curvature crossing the esophagus, a downward pointing pylorus, 2 air fluid levels, or a lowering of the gastric fundus, which are all suggestive of the gastric torsion that is associated with malrotation. Malrotation is usually asymptomatic, but people can have clinical indications of bowel obstructions, volvulus, or bowel incarceration that can compromise the blood flow to the involved bowel, leading to tissue death or necrosis. A volvulus is when a loop of intestine twists around itself and the mesentery that supplies it, causing a bowel obstruction. Surgery is the treatment to correct a volvulus or bowel incarceration. In this image, the small bowel is located on the right side of the abdomen and the colon is on the left, which is indicating malrotation. I have an arrow pointing to where the terminal ileum is entering the left-sided cecum, which, due to the malrotation, is located on the right. Alright, this is another highlight star, just so you're aware. Hirschsprung disease is the absence of neurons in a bowel wall, typically sigmoid colon. A malformation of the parasympathetic nervous system results in the absence of neurons in the bowel wall, prevent the normal relaxation of the colon, and impairs the normal colon peristalsis. The results in a function obstruction with gross dilation of the colon to the point where the segment that is narrow and constricted. Hirschsprung disease becomes very apparent shortly after birth when the infant has their first bowel movement and the abdomen becomes distended. It's important to diagnose this disease early because it can progress to toxic megacolon if left untreated, which can develop from bacterial overgrowth that will lead to fluid and electrolyte imbalances that can cause death. Although the exact cause of Hirschsprung disease is unknown, a link to the inheritance of the rearranged during transfection proto-oncogene on chromosome 10 has been established. Radiographs might show an obstructive bowel gas pattern at the ganglionic colon and show severe stool burden. Contrast enemas will demonstrate a transition from the narrow rectum and distal colon to a dilated proximal colon. Please note barium is a direct contraindication with those known or suspected to have a toxic megacolon. Initial treatment may consist of a temporary colostomy until surgical resection is possible later. Sometimes multiple surgeries will be necessary to correct this anomaly. This is another highlight star, just so you know. Meckel diverticulum is a congenital diverticulum of the distal ileum. It follows what clinicians call the rule of twos. It occurs in 2% of the population, is usually present before the age of 2 years old, and is located along the ileum within 2 feet of the ileocecal valve. Complicated cases are associated with ulceration, bleeding, perforation, intussusception, volvulus, or internal herniation. It can be asymptomatic, but if there are symptoms, then often manifest before the age of 2. Children can develop peptic ulcers, and a common sign is repeated episodes of bleeding from the ulcer resulting in blood in the stool. Adolescents and adults may experience blood in the stool, but more often they will have cramping, vomiting, and bowel obstruction. The symptoms will mimic those of appendicitis except for the location of the pain. Diagnosis is very difficult. Nuclear medicine Meckel scans are useful in diagnosing this anomaly when an ectopic gastric mucosa is present. Treatment for symptomatic Meckel diverticulum involves surgical resection of the diverticulum. This is another highlight star. Gluten-sensitive enteropathy used to be known as celiac sprue or celiac disease. This disease is an autoimmune hereditary disorder involving increased sensitivity to the gliadin fraction of gluten. Gluten is an agent found in wheat, barley, and rye products and can interfere with normal digestion and absorption of food through the small bowel. Common symptoms include diarrhea, flatulence, weight loss, abdominal distension, and abdominal pain. Individuals may also present with nutritional deficiencies. Radiograph changes during the small bowel series will generally demonstrate segmentation and dilution of the barium column. It will demonstrate what's called flocculation, which is when the barium will resemble tufts of cotton, and edematous mucosal changes. The mucosal changes will cause the jejunum to have a dilated appearance with folds that resemble that of the ileum instead of the delicate and feathery folds of the normal jejunum. Diagnosis is confirmed by a biopsy of the small bowel. Treatment consists of avoiding substances containing gluten. Vitamin therapy is also used to ensure the patient is receiving adequate nutrients. Alright, we are moving on to inflammatory diseases. So strictures are abnormal narrowings that can be benign or malignant. Benign strictures are often smooth with tapered or obtuse margins, and the mucosa may be normal or abnormal. Abnormal mucosa presents during active inflammation or infection, whereas normal mucosa tend to be chronic. Malignant strictures often have unsmooth mucosa and irregular contours with acute or shouldered margins. If a patient were to swallow any household cleaners, it would cause complications as well. Endoscopy is usually performed to assess for damage to the esophagus, and the esophageal lesions are treated with corticosteroid therapy. Cases of perforation may require surgical intervention. Strictures can also be a result of a tumor infection or post-inflammatory scarring from GERD or radiation therapy treatments. Treatment for benign strictures may require repeated endoscopic dilation. Dilation is not a solution for malignant strictures as the tumor will continue to grow. It can be used for short-term palliative care, but each time increases the risk for perforation. Instead of using balloons for dilation in malignant strictures, a stent may be used. Gastroesophageal reflux is the retrograde flow of the gastric acid and contents into the esophagus. GER is often associated with heartburn and/or dysphagia. When GER becomes more frequent and persistent, it can progress to gastroesophageal reflux disease, which is GERD. Chronic symptoms and complications like esophagitis, a stricture, or damage due to esophageal mucosa. Reflux esophagitis is the primary cause of esophageal inflammation. GERD may also result from esophageal motility disorders, hiatal hernia, delayed gastric emptying, or increased intra-abdominal pressure. A troubling risk of GERD is the development of Barrett esophagus, with is a pre-malignant diagnosis confirmed by biopsy. Various tests and procedures are used to diagnose GERD. Tests can include esophageal manometry to determine the pressure in the upper and lower esophageal sphincters, pH monitoring of the esophagus, and acid perfusion testing. Imaging may include an upper endoscopy, esophagram, or upper GI procedure. Treatment would be lifestyle and dietary changes. This is another highlight star. Peptic ulcer is an erosion of the mucous membrane of the lower end of the esophagus, stomach, or duodenum. The most common sites are in the duodenal bulb and on the lesser curvature of the stomach. Current studies suggest that the peptic ulcers result from disruption of the normal mucosal defense and repair mechanisms. Causes may be NSAIDs and H. pylori bacteria, which will alter the mucosa, making it more susceptible to the effects of acid normally residing in the GI tract. Pain is a symptom of peptic ulcer and is usually above the epigastrium and radiating into all parts of the abdomen. Food ingestion and antacids may provide temporary relief, but the pain will return when the stomach is empty. Diagnosis is made primarily using an upper endoscopy, but a double contrast GI studies can be performed. Peptic ulcers are usually treated with multi-drug therapy combinations. The drug regimen includes a combo of antibiotics and acid-blocking drugs. Surgery would only be required for complications of ulcers such as obstruction, bleeding, or perforation. Problems may also include pneumoperitoneum or peritonitis if the ulcer perforates into the abdomen. Gastroenteritis is a grouping of multiple inflammatory disorders of the stomach and intestine. Erosive gastritis appears to be a precursor to gastric ulcer formation and results from a compromised mucosal barrier within the stomach. Causes include Crohn's disease, ingestion of NSAIDs, alcohol, and steroids, physical stress or trauma, and bacterial, viral, or fungal infections. Acute gastric erosions heal rapidly once the cause is eliminated. This can be diagnosed with a double contrast examination of the stomach. Radiographically, it's demonstrated by decreased distendability of the antrum in combination with thickened mucosal folds. Treatment consists of proper fluid management and relief of nausea and vomiting. Alright, this is a highlight star. Basically just know what Crohn's disease is. Regional enteritis, or Crohn's disease, is a chronic irritability bowel disease of unknown cause that is increasing in prevalence. Research indicates the disease is more prevalent in individuals with a family history of the disease. Individuals with the disease are primarily affected by an unregulated intestinal immune response to various agents like food or environmental factors that can cause that can result in crypt cell inflammation and abscesses, which can lead to development of ulcers. Symptoms include abdominal pain, diarrhea, bloody stool, weight loss, nausea, vomiting, and malnutrition from vitamin deficiencies. Crohn's disease results in fibrotic scarring, which may give rise to mechanical obstruction of the bowel. During barium studies, this can give a cobblestone appearance due to a combination of mucosal edema and crisscrossing of the fine ulcerations. The string sign is demonstrated when the terminal ileum is so diseased that stenotic and that the barium mixture can only trickle through a small opening that looks like a string, which is demonstrated in the picture. Diagnosis is based on a combination of clinical, laboratory, histologic, and imaging findings with no single diagnostic test being the gold standard for reaching a diagnosis. Common imaging used is capsule endoscopy, CTE, MRE, CT, colonography, and sonography. Treatment includes drug therapy to decrease inflammation, relieve diarrhea, and treat the infection. Bowel resection to remove the involved section of the intestine is necessary approximately 70% of the time. The disease is rarely cured, but rarely fatal. Alright, this is also a highlight star. Appendicitis is an inflammation of the vermiform appendix resulting from an obstruction usually caused by a fecalith or more rarely a neoplasm. Appendectomies are the most common abdominal surgery emergency in the United States. The obstruction leads to inflammation and distension and affects the blood supply to this portion of the bowel. Poor blood supply can gangrene, perforation, and possible rupture. Once the appendix ruptures, the infection spreads to the peritoneum, which can lead to general peritonitis that could result in death. Signs and symptoms include initial pain in the epigastrium that moves to the right lower quadrant and becomes persistent. Nausea and vomiting, low-grade fever, sudden onset of constipation, and elevated white blood cell count. White blood cells help distinguish appendicitis from other colicky abdominal disorders. Diagnosis may not require imaging because the presentation of the disease is often sufficient for reliable diagnosis to indicate surgical treatment. When imaging is needed, CT is preferred and sonography is used secondarily. Treatment is surgical removal of the appendix, and in cases of early surgical intervention, the mortality rate is low. However, complications such as abscess formation, perforation, or peritonitis place the individual at a greater risk and significantly increase the recovery period. Alright, so this is another highlight star, just knowing what ulcerative colitis is. Ulcerative colitis is an IBD of the colonic mucosa. Its cause is unknown, but it is thought to be an autoimmune disease. It's 4 times more common in Caucasians, especially in Jewish people of Eastern European descent. A familial tendency to develop this disease also exists and is more common in first-degree relatives. Signs and symptoms of UC include intermittent spells of bloody diarrhea and abdominal cramping. Possible complications are colon strictures, toxic colitis, or megacolon and rupture. People with UC have a greatly increased incidence of colon cancer, especially if the entire colon is affected over 10 years. Diagnosing UC is usually done by sigmoidoscopy and colonoscopy. Because 90 to 95% of cases involve the distal colon or rectum, barium enemas are sometimes performed to diagnose and assess the progression of the disease and its complications. When filled with barium, the normal, smooth colon outline will become irregular because of the ulceration present. Radiographic presentation is easily recognized by the loss of colon, which may be referred to as the lead pipe sign. Thickening of the mucosa and wall are sometimes referred to as thumbprinting. There is currently no known cure for UC. Treatment involves efforts to regulate the immune system with medical therapy and dietary restrictions. Alright, so basically, you just need to know that these two are different. So ulcerative versus regional Crohn's. So ulcerative colitis is the disease of mucosa of colon, begins at the anus and ascends, often results in megacolon and bowel perforation, frequently progresses to cancer. And then Crohn's disease affects all layers of bowel wall, begins in terminal ileum and cecum, and descends often with skip areas. Rarely it produces megacolon or bowel perforations. Alright, this is another highlight star. So varicose veins are abnormally lengthened, dilated and superficial veins. Those in the esophagus are referred to as esophageal varices. The cause of esophageal varices are a result of portal hypertension. Conditions that cause resistance to the normal blood flow through the liver cause a bypass of the normal venous drainage mechanism. Instead, blood is directed through the esophageal and gastric collateral veins. The increase in the blood flow through these channels result in venous dilation and formation of varices. Esophageal varices are more likely to be demonstrated during barium studies in a recumbent position because gravity causes poor visualization in the erect position. Thin barium shows the varices as worm-like and wavy margins, filling defects within the column of barium. CT and MRI studies provide the best imaging of esophageal varices and other effects of portal hypertension. Individuals with esophageal varices are subject to rupture with hemorrhage, which may be massive and often fatal. Treatment may consist of endoscopic sclerotherapy, banding, ligation, or infusion of vasopressin, which is a natural hormone useful in stopping hemorrhage. Compression of the varices through a balloon tamponading may be used occasionally. TIPSS stands for the transjugular intrahepatic portosystemic shunt. That is applied via interventional radiology or during surgery that may be used to help redirect liver blood flow, thus reducing portal hypertension and easing venous pressure in the esophageal and gastric collateral circulation. Alright, we are going to be talking about degenerative diseases now. This is a highlight star, by the way. A hernia is a protrusion of an organ through an opening in muscle or tissue intended to hold it in place. Abdominal hernias can occur as internal or external. There are several different kinds, and you can see them below, or on the slide, I should say. If a herniated loop of bowel can be pushed back into the abdominal cavity, it is said to be reducible. If it is stuck and cannot be reduced, it is called incarcerated. This can lead to a bowel obstruction. If the constriction is tight enough to cut off blood supply to the bowel, it is called a strangulated hernia. Prompt surgical intervention is required in this case to avoid necrosis. CT is the best modality of choice for identifying abdominal hernias as well as signs of resultant bowel obstruction. CT scans should be performed with both oral and IV contrast. Alright, so this is another highlight star. Hiatal hernia is a weakness of the esophageal hiatus that permits some of the portions of the stomach to herniate into the thoracic cavity. They occur in about half of the population over 50 years of age. Hiatal hernias are classified as either sliding or paraesophageal. Sliding hiatal hernias occur when a portion of the stomach and esophagogastric junction are both situated over the diaphragm. This type of hernia is the majority of all hiatal hernias. A Schottky ring is often visible with this condition and consists of a concentric narrowing to the lumen at the esophagogastric junction. It's caused by an inflammatory reaction in the esophagus from reflux and can lead to a symptomatic stricture. It is of no clinical significance unless it produces narrowing sufficient to cause dysphagia, usually less than 13 millimeters in diameter. A 13 millimeter barium tablet can be administered during an esophagram to measure the width of the esophagus and determine if a Schottky ring has developed. Rolling or paraesophageal is less common. This occurs when a portion of the stomach or adjacent viscera herniates above the diaphragm, but the esophagogastric junction remains below the diaphragm. A rolling hiatal hernia is typically asymptomatic but can be life-threatening because of the risk of volvulus incarceration or strangulation of the hernia. An esophagram or upper GI can best pinpoint the herniation and provide classification on the type of hernia and provide better measurements. Treatment includes minimizing discomfort, and paraesophageal hernias generally require surgery. A gastric volvulus is an abnormal rotation of the stomach with greater than 180-degree rotation. A combined volvulus is usually a result of chronic volvulus that begins as either organoaxial or mesenteroaxial. Gastric volvulus may present as a distended stomach in the chest or upper abdomen on an upright chest radiograph. A pneumoperitoneum may also be present if perforation has occurred. An upper GI is helpful with diagnosis. Symptoms may include severe epigastric pain, retching without vomiting, and an inability to advance an NG tube. Chronic cases may be asymptomatic, but those with symptoms need immediate surgical intervention. This is another highlight star. Normal bowels are always active with peristalsis. When lesions are present, they can interfere with that activity and lead to a bowel obstruction. A mechanical bowel obstruction occurs from a blockage of the bowel lumen. It can be caused by hernias, tumors, volvulus, intussusceptions, or post-op adhesions. A simple obstruction does not involve the blood supply, but a strangulation may lead to bowel infarction. Intussusception is a segment of bowel that telescopes into a distal segment and is driven further into the distal bowel by peristalsis. Since the bowel is attached to the mesentery, it involves the blood supply. A radiograph may show a soft tissue mass or small bowel obstruction. A small bowel series may demonstrate what appears to be a coiled spring. Ultrasound and CT will appear as a target sign. Diagnosis is initially based on clinical signs and symptoms, including abdominal distension, abdominal cramps, and vomiting, sometimes progressive bloody stools. Treatment is a surgical intervention. Paralytic ileus is also known as adynamic ileus. It's a failure of normal peristalsis that could be caused by a variety of factors such as surgery, intraperitoneal or retroperitoneal infections, certain drugs, electrolyte imbalance, pancreatitis, or simply as a reaction to any stressful illness. It generally lasts no longer than 3 days with proper medical treatment. Signs and symptoms include distension of the abdomen, abdominal cramping, and vomiting. Treatment consists of NG suction and medical stimulation of the bowel to restore peristalsis. In some cases, a colonoscopy or rectal tube decompression may be required. Alright, this is another highlight star. A diverticulum is a bulging pouch or sac of variable size that occurs normally. They can form anywhere along the GI tract. Esophageal diverticula occur when the mucosal outpouchings penetrate through the muscular layer of the esophagus or fibrotic disease and retracts into the esophageal wall. Two primary types are pulsion and traction. Pulsion involves the mucosa only and upper or lower 1/3 of the esophagus. It results from a muscular weakening of the esophagus that allows the mucosa to herniate outward. Different types of pulsion diverticulum are Zenker diverticulum and Killian-Jamison diverticulum, usually asymptomatic until they are large and cause issues. Failure to control the effects of diverticula through diet modifications may result in the need for surgical removal. Alright, so diverticular diseases. Gastric diverticula occurs in the fundus or antrum of the stomach. This type is more common and are usually congenital, usually asymptomatic until they become large and cause issues like ulcers or bleeding. Gastric carcinoma has been found in fundal diverticula. Antral diverticula are from the greater curvature of the antrum and have been associated with pancreatitis, gastric outlet obstruction, and malignancy, usually discovered incidentally through CT or upper GI. Small bowel diverticula are less common. They differ from Meckel diverticulum because they are normally asymptomatic. Complications can include diverticulitis, bacterial overgrowth, hemorrhage, perforation, obstruction, and inversion of diverticulum that can lead to intussusception. In cases of complication, treatment depends on what the complication is. Diverticulosis is the presence of diverticula without inflammation and is seen in all parts of the colon, most frequently in those over 40, and are found in the sigmoid colon. They are associated with hypertrophy of the muscular layer of the bowel and occur most often in the terminal branches of the mesenteric vessels that are found within the bowel. Contributing factors include pressure gradient between the lumen and the serosa of the bowel and areas of weakness within the bowel wall. Diverticulitis is the inflammation of diverticula and can be exacerbated by feces lodging in the diverticulum. Signs and symptoms include pain, tenderness, fever, and an increase in white blood cell count. Because of these symptoms, it tends to be confused with appendicitis. Imaging is not always needed to make a diagnosis. In the past, if imaging was required or requested, a barium enema would be performed. However, this has now been replaced with CT. Radiographic signs for diverticulitis in a barium enema are limited but could demonstrate outpouching of the mucosal wall. Also, if a BE was the modality used, it's important to remember barium would be contraindicated due to the high risk of perforation. So you'd want to be using a water-soluble contrast. Treatment is centered on reducing inflammation and infection. Treatment can include antibiotic therapy or surgical resection. This is another highlight star. So we are talking about neoplastic diseases now. Tumors in the esophagus normally occur in the lower one-third of the organ and can be either malignant or benign. Leiomyomas are the most common benign tumor. They are smooth muscle tumors that are commonly discovered incidentally. During the exam, they can present as intramural filling defects in the barium outlined esophageal wall. The exact location is found during a CT. Treatment is surgical removal. Other benign lesions include squamous papillomas, villus adenomas, and hamartomas. All are rare and have pre-malignant potential. Esophageal cancers are 4 times more likely to occur in males and have poor prognosis due to normally finding the disease late. If found early, there is a better survival rate. Presenting symptoms include dysphagia, painful swallowing, pain, weight loss, early satiety or feeling full, and anorexia. Risk factors include alcohol consumption, tobacco use, chronic reflux, esophagitis, HPV, achalasia, causative ingestion, radiation exposure, head and neck cancer, and celiac disease. Squamous cell carcinoma occur in squamous epithelium and are most commonly found in the body of the esophagus. Adenocarcinomas result from malignant degeneration of columnar metaplasia. This occurs in the distal esophagus and esophagogastric junction. These two types of cancers have different clinical and radiographic features. Squamous cell may demonstrate mucosal destruction, ulceration, narrowing, and sharp variance between normal and malignant tissues. Adenocarcinoma appears early on as plaque-like lesions, and as it advances, it appears as infiltrating lesions with irregular narrowing of the lumen and abrupt asymmetric borders. Regardless of the type, they are diagnosed through biopsy of the lesion and are imaged using CT studies of the neck, chest, and abdomen. A surgical technique called the Ivor-Lewis esophagectomy is used to remove the malignancy. Adenocarcinoma is directly linked to Barrett esophagus. Barrett esophagus involves progressive columnar metaplasia of the distal esophagus because of chronic gastroesophageal reflux and is a direct precursor to the malignancy. I've mentioned columnar metaplasia a few times in this slide. Columnar metaplasia of the esophagus is a complication of gastroesophageal reflux disease, or GERD. Tumors of the stomach are mostly malignant, with 95% being adenocarcinomas. These tumors are metastasize easily because they are a variety of routes the disease can take from the stomach. Incidence of gastric cancers varies greatly based on geographic location. For example, people in Japan are 5 times more likely to have this type of cancer than those in the US. It is more common between the ages of 50 and 70 and more common in males than females. Early cancers do not have specific symptoms, which is why this type of cancer is usually diagnosed late. Symptoms include persistent GI pain, bleeding, vomiting, loss of appetite, weight loss, and early satiety or full stomach. Primary diagnosis is done by performing an upper endoscopy with biopsy. An upper GI may be requested for early onset symptoms. During an upper GI, malignant tumors have a relative rigidity of peristalsis, and irregular appearing filling defects persist during compression. The filling defects may have complete or partial radiolucency within the barium column as barium pools around the tumor. Treatment is surgical removal. Small bowel neoplasms represent fewer than 5% of all benign and malignant GI neoplasms. Most small bowel cancers occur in the duodenum and proximal jejunum. 2 different types are adenocarcinoma and lymphoma. Predisposing factors are piloposis, that are found in other areas of the GI tract: Kaposi sarcoma, Crohn's, and celiac disease. These cancers are diagnosed by endoscopy procedures with biopsy. Small bowel series may also be used to aid in the diagnosis. Treatment is surgical resection. Colonic polyps are small masses of tissue arising from the bowel to project inward within the lumen. Most are hyperplastic and benign. An adenomatous polyp is a benign tumor that has the potential to become malignant. Adenomas are the most common neoplastic polyp, mostly located in the left colon and particularly in the rectosigmoid areas. Syndromes associated with multiple polyps may include familial polyposis, Gardner syndrome, and juvenile polyposis. Even benign polyps should be removed. Those over 2 centimeters in size have a malignancy rate of over 50%. Polyps are asymptomatic. Polyp appearance radiographically as rounded filling defects or contour defects in the barium shadow. Diagnosis is made by sigmoidoscopies and colonoscopies. This is another highlight star. Colon cancer is the third most common cause of cancer, mortality being found in both male and females. The chance of colon cancer rises significantly over the age of 40 and doubles with each decade. Risk factors include obesity, physical inactivity, diets high in red meat and processed meats, smoking, and alcohol abuse. Colon cancer tends to cluster in families, with the risk of the disease in people with one affected first-degree relative being 2 to 3 times higher than in the general population. Adenocarcinoma is the most common type of colorectal cancer. It's diagnosed by fecal blood testing and imaging tests like proctosigmoidoscopy, colonoscopy, barium enema, CT, CTC, TRUS, or ultrasound and PET. Adenocarcinoma has a radiographic appearance of a napkin ring or apple core lesion. Symptoms vary depending on where the lesions are located. Lesions on the right may produce no symptoms early on, often becoming quite large, ulcerating and even bleeding without other significant symptoms. Lesions on the left present more with obstructions and bleeding. There are various imaging evaluations that can be caused for colon cancer. Double contrast barium enemas, CT colonography, colonoscopy, CT and MRI are all used to diagnose those stage colon cancer. Without treatment, the cancer can spread to the liver, but fortunately the lesions do not spread quickly, so the prognosis is good. The primary means of treatment are surgical excision of the primary tumor and surrounding bowel if possible. A colostomy may be done depending on where the tumor is. Radiation and chemotherapy is also utilized. This is an image of a CT scan that shows extensive metastatic disease from the colon to both lobes of the liver. Alright, so that is the completion of chapter 5. I think I hit all of my highlight stars. If not, I obviously apologize. This summary has the pathologies that are additive or subtractive pathologies, so this would be very useful for your exposure factor assignments. If you have any questions, please let me know, and have a good week, everybody.